Welcome to our Perineal Care course, brought to you by Hello Baby and Surrey and Sussex Healthcare Trust. Firstly, we'd like you to think about what you would like to gain from this session. Do you have a particular question that you'd like answering? Why did you join this course? Or are you just here for general information? If you do have any questions, keep them in the back of your mind, and if they're not answered by the end of the session, you can contact us and we can answer any questions that you might have. So first up, let's look at the contents. We're going to have a look at what are perineal tears? How do we reduce the risk of them? What are the different degrees of tearing? How to care for your stitches if you have them? We're going to look a little bit at pelvic floor exercises, looking after yourself. We're going to touch on consent, and finally, we'll have some additional resources for you. What are perineal tears? For those of you that don't know, the perineum is the area between the anus and the vagina. It's that bit of skin in the middle. We know that this area can tear during childbirth, and it's actually quite common. It can occur inside the vagina, parts of the vulva or the labia on the outside. And for more first-time mothers, this is more common. In fact, approximately 9 in 10 first-time mothers will experience some kind of tear, graze, or episiotomy, which is a cut. But what we also know is that most of these are minor and they heal very quickly. So what we'd like to do today is eliminate some of the fear around them. Why do tears occur? The most obvious reason is that the baby, as it's come down the vagina, has stretched the vagina and the perineum during birth, which can cause tearing. But additionally, we know that there's a range of other factors, including the increased use of forceps during birth, which is when the instruments increase the diameter. Also, if it's your first baby and your perineum has never stretched in this way before. But there's also other factors, such as maternal age over 40, a particularly large baby, your ethnicity, and more. So what can you do to reduce your risk of perineal tears? There's lots and lots of growing research around perineal massage. Perineal massage can be started from 34 weeks, and the aim of perineal massage is to start relaxing the perineal muscle and preparing it ready for childbirth, so it's ready to stretch and is less likely to tear. We'll talk more about perineal massage a bit later. Also, staying active in your pregnancy and your labour can be really helpful. This aids your baby into an optimal position for birth, and the better the position of the baby, the less likely it is that you will have a severe tear. Breathing techniques can also help reduce your risk of tears. It's important to practice breathing techniques in your pregnancy. I know you might think, well, it's just breathing, I'm sure I can pick it up in labour. But actually, it's much harder than you think. So using these breathing techniques throughout your pregnancy can then prepare you to use them during your birth. And we know that by using these slow method ways of breathing, it can help to reduce your risk of tears by breathing the baby out slowly during the birth. What can be done to try and reduce the risk of perineal tears during the birth? Firstly, birth position can be really important. We know that by giving birth in positions such as an all-fours position, kneeling, or a side-lying position, this can reduce your risk of perineal tears, whereas positions like lying on your back or squatting can actually put more pressure on the perineum. The next thing is communication or coaching from your midwife. At the point when you're pushing your baby out and you think, yes, I'm just going to push really hard and get this baby moving, your midwife at that point might ask you to slow things down, to breathe slowly, to pant, or to blow out the candles. There's lots of different things that your midwife might suggest, but the outcome is just to slow your breathing down so that your baby stretches that perineum nice and slowly to reduce your risk of tearing. A hands-on approach might also be used at birth. This is usually discussed with you beforehand, but in some very rare occasions, if it's happening quickly, the midwife might use the hands-on approach and ask you as she's doing so. This can slow the baby's head down and also means that we can use a warm compress. We know that warm compress on the perineum during the second stage of labour when you're pushing can significantly reduce the risk of severe tears. It minimises the need for an episiotomy and decreases pain by giving warmth and relaxing the area, increasing the tissue elasticity. As you can see from the picture, we're doing a quality improvement project here at SaSH, which means that our midwives will be focusing on your perineal care, thinking about your birthing position, whether we need an extra pair of hands or someone else in the room. Your midwife will continually assess throughout, use good communication, a hands-on technique with a warm compress. They will evaluate for episiotomy, although the need for this is rare. And finally, they will try to ensure that the head is birthed slowly in order to reduce tears. Perineal massage. We briefly touched on perineal massage a bit earlier in the course. Perineal massage is the massage of the area of the perineum between the vagina and the anus. This can be started from 34 weeks of pregnancy. And to prepare yourself, initially you might want to take a warm bath or a shower just to relax and warm up the muscles. It's good to make sure that your nails are short and that you're in a nice comfortable position. This could be different for everybody. So for some of you, sitting cross-legged, if you can bring your arms around and under your bump, might be comfortable for you. You might wish to have one leg up on a stool or a chair. You may wish to be lying on your side. Everybody's different. Do whatever feels comfortable for you. You may wish to use a lubricant such as KY jelly, Vaseline, or a natural oil. To do the perineal massage, one of the first things is to insert your thumb into the vagina and hold down on the base of the vagina firmly for about a minute. This may feel slightly uncomfortable, but that's okay. It shouldn't be painful though. You may then want to gently massage in a U-shaped movement for about 2 to 3 minutes, and I have some follow-up videos to show you how this is done. It's advised that you repeat this daily or when possible. We really advise about 2 or 3 times a week. And for some people, they may wish to do this with a partner, while some people might want to do it alone. Again, it's whatever feels more comfortable for you. The main thing about perineal massage is just to remember that there's no right or wrong. If you don't like it, you don't have to do it. Although the research suggests that it is really good for reducing perineal tears, you do not have to do it if you don't like it. Here we have a short video from Leeds Teaching Hospitals on perineal massage. It just gives you some visuals and another good explanation of how perineal massage can help.
From 34 weeks, it's a really good idea to start doing some perineal massage in preparation for the birth of your baby. Your perineum is a triangular muscle that sits between your vagina and your back passage. This muscle needs to stretch to make space for your baby. Massaging in pregnancy can help this muscle stretch more easily and reduce the risk of you tearing. Other things that can help reducing the risk of tearing are using a warm compress during the second stage of labour as baby's head is advancing. Your midwife may ask for your permission to put her hand on your perineum and on baby's head to ensure that baby's head is delivered slowly and reduce the risk of any tears occurring. If you plan to deliver in water, it is not possible for the midwife to put her hand on baby's head or your perineum and guide baby's head out for delivery. And this is why you are at an increased risk of tearing if you choose to have a water birth. If your midwife is concerned that you may tear badly, then it is recommended that we do an episiotomy, which is a small cut on the perineum muscle. Your consent will be gained prior to this being performed. If an episiotomy is required, an injection of local anaesthetic is used to numb the area prior to the cut being performed. Significant tears on the perineum can involve your anal sphincter. It is recommended that you have a spinal anaesthetic, which is similar to an epidural, so you will be awake but completely numb so that the surgeon can repair the sphincter and the muscle adequately. For more information about perineal massage in the antenatal period, please go to the Trust website.
Here's another short video which has really good graphics of perineal massage to show you how it should be performed.
To start and how to do perineal massage. Massaging your perineum, the skin between your vagina and your back passage, from 34 weeks pregnancy may reduce the chance of a perineal tear as it prepares your perineum to stretch more easily during birth. Ideally, you should perform the massage 4 times a week for 5 to 10 minutes each time, but don't do it if you have an active infection, for example, a urine infection, herpes or thrush. Before beginning perineal massage, empty your bladder and make sure your hands are clean. Use a mirror to become familiar with your perineum. You may also want to take a warm bath or a shower to help relax. Find a comfortable position. This could be sitting with your legs outstretched and back supported, or standing with your foot on a chair. Lubricate your fingers and thumb with a lubricant or pure vegetable oil, then insert your thumb to about 1 inch into the vagina. Massage gently in a U shape from towards your back passage to the other side of the vagina. The pressure should be firm and may be uncomfortable. Try adding some sustained stretches and holding for 10 to 30 seconds.
Stay ahead in tech. Sharpen your competitive edge with Pluralsight. Our hands-on learning.
The pool cohort study. So you might have heard in the video from Leeds Teaching Hospitals that giving birth in water can increase your risk of tearing, and that's quite old information. Since then, we've had the pool study, which is the largest research project in the UK to look at the use of water during labour, and it offers clear, high quality evidence about the experiences and outcomes for mothers and babies during water birth. The aim of the study was to look at women with no known risk factors cared for by NHS midwives and look at whether giving birth in water was as safe as leaving the pool to give birth on land. The great thing is that the results showed reassuring evidence that water birth does not increase the risk of serious tears for mothers, and also it does not increase health problems for babies born in water. So this is really reassuring because when you're under the water, we cannot use the same hands-on technique that we do if you're out of the water because we don't want to stimulate the baby under the water. However, this now shows that there is no increase in the risk of serious tears. Degrees of tearing. Let's take a moment now to look at the different types of tears that can occur. In the top left-hand picture, you will see what is known as a first-degree tear. A first-degree tear is usually a graze to the skin, okay? It can occur in the perineum, like shown in the picture. It can also occur in the vulva, the labia, or inside, closer to the urethra or the clitoris. Grazes, however, can be left to heal naturally. Although they may be a little bit stingy, they usually cause no ongoing problems. Moving across to the picture on the right-hand side at the top, you'll see a second-degree tear. The second-degree tear means that it's now affected the muscle as well as the skin. Second-degree tears can be sutured in the room by your midwife whilst you're spending time with your newborn baby. If you've already had an epidural, we can continue with the suturing straight away. However, if you haven't had an epidural, we will give you some local anaesthetic into the area to make sure that you are completely numb before we begin suturing. Moving down, you have the third and fourth degree tears. Third degree tears are tears in the anal sphincter, which has 3 layers. Therefore, third degree tears are split into 3A, 3B, and 3C. Whilst a fourth degree tear means that the tear has gone into the rectum. Third and fourth degree tears need to be sutured in theatre under a spinal anaesthesia or epidural top-up by an obstetric doctor. If you have a third or fourth degree tear, you will also be offered a physio appointment 6 weeks after birth to make sure that you have healed and everything is working properly, and you will be offered antibiotics in the immediate postpartum period. Additionally to these, we have an episiotomy, which is a cut. This is usually sutured in the room like a second degree tear. Why episiotomy? As I just mentioned, an episiotomy is a cut to the perineum. If you was to picture the vagina as a clock, with the bottom of the vagina being 6 p.m, the cut would be made at 7 or 8 p.m. This means that the cut is made away from your bottom. So if a tear was to happen and extend, it's going to go off to the side away from your bottom. The aim of this is to avoid your more serious OAC tears. We don't just do episiotomy for the sake of them. It's most commonly done with an assisted delivery, especially a forceps. And this is because when we add in a forceps, you're now not just birthing a 10 centimetre head, you're birthing a head plus forceps. This means that you're more at risk of a tear and a more severe tear. So by doing the episiotomy in advance before adding in the forceps, this reduces your risk of that OAC tear. And this should be discussed with you before it happens. Another reason that we might do an episiotomy is, say for example, your baby's really low in the birth canal and the head's trying to come, but the perineum is still thick and not stretching, and your baby is now becoming really distressed. Then it might be that a conversation is had at that point as to doing an episiotomy to avoid that big tear again. An episiotomy would never be done without your consent, and there always should be time for at least a quick conversation around it. Because an episiotomy is cut away from your bottom, it is usually a second degree tear, which means it affects the skin and the muscle. This means that it can be sutured in the room by your midwife whilst you're spending time with your newborn baby. Let's take a moment now to look at our local stats from Surrey and Sussex Healthcare Trust for 2025. For example, let's look at January. We had 167 vaginal births in total. 65 of those had no tears whatsoever. 28 had just a graze, and 64 had grade 2 tears which were sutured in the room. Of those 167, only 10 had third-degree tears and none had fourth-degree tears. If we compare this, say, to September, for example, we had 183 vaginal births, 61 had no tears at all, 32 just had a graze, and 85 had second-degree tears, which could be sutured in the room, whilst 4 women had third-degree tears. So out of 183 vaginal births, only 4 tears were OAC. Here we can see the stats split down into first births and subsequent births. So if we just take a look at January again, we had 55 vaginal births for women that were having their first babies. 23 of those had no tears at all, and 26 had first or second degree tears. Then if we look at multiples, which means you've had a baby before, and look at January, there were 112 vaginal births, 42 of which did not need any sutures at all. 23 had grade 1 and 43 had grade 2, whilst only 4 of the 112 had OAC tears. This is what it looks like on a chart. So there you can see that the brown at the top is no sutures needed at all. The orange at the bottom is your grade 1 and the grey in the middle is your grade 2. And then you can see just small specks of colours for the more serious tears. And here it is split into your first birth and your subsequent birth. Again, we can see that the majority of women either had no tearing or just sutures that needed to be done in the room for second degree tears. This is what it looks like as a percentage if your brain learns that way. So, for example, in January, 39% of women did not need any stitches, 38% had a second degree tear, and 17 had a first degree tear, while just 2% had a 3A, 3% had a 3B, and 1% of women had a 3C tear, and no percent of women had a fourth degree tear. Again, we'll look at that for September. 33% did not need sutures at all. 46% had second degree tears. That's nearly half of women had second degree tears that could be sutured in the room. And another 19%, so nearly 20%, had just a graze. And here that is again split down for women whose first baby versus subsequent baby. So if we have a look for those first babies, 42% of women did not tear at all. 38% of women had a grade 2 and 9% had a grade 1. So that means that 89% of women had a grade 2 tear or less for their first birth. In the subsequent births, we see similar results, with 38% with a second degree, 38% with no tearing at all, and 21% with grade 1 tears. So that's 97% of women who had a first, second, or no tear at all. And here's what that looks like again as a graph. Finally, here you can see it as a pie chart, because who doesn't love a pie chart? So you can see that the red, the orange, and the grey is your first, second, and not needing sutures. And there's just a small amount there of the total amount of women that needed additional help with their sutures. Again, for your first birth and subsequent births, much smaller rates there. So hopefully what this does is it just makes you feel a little bit more reassured about how unlikely it is that you will have the more severe tears. And also from doing this course and learning about all of the things that you can do to help, staying upright, changing position, doing perineal massage and looking after yourself, which will hopefully help you and help us to reduce the risk of OAC tears even further. So let's say you do have some stitches. How are you going to care for them? First and foremost, good hygiene is extremely important. We recommend that you clean the area a few times a day using only water and no soap. Stitches are dissolvable, so you don't want to add in anything that could dissolve the stitches sooner than you would like. We recommend that you wash or shower at least once a day and change your sanitary pads regularly. We normally recommend that you change your sanitary pad about every time that you feed your baby. So you know that every couple of hours you are changing your pads. Even if they're not dirty, we know that they can be sweaty, and this can be a breeding ground for bacteria. So by changing those pads regularly, it really helps to keep the area clean and dry. Once you've washed, make sure that you keep the stitches dry by patting gently from front to back, either with some soft tissue or with a dry towel. We recommend that you wear breathable materials and loose clothing, such as loose trousers or a skirt with some cotton underwear. It's really important that you wash your hands both before and after you go to the toilet or change your sanitary pads. If you go to the toilet and you wipe and you haven't washed your hands, there could be bacteria that spread from your hand onto the tissue and can therefore be moved into the wound. So by washing your hands before you go to the toilet or change your pad, you're instantly eliminating that risk. It's also really important that you just have a good, balanced, healthy diet and drink lots of water. What should I expect? Well, we'd be lying if we said that some pain or soreness isn't normal. Okay, it's okay to have a little bit, but the pain should be relieved with over-the-counter pain medication. So, for example, paracetamol, or if you could take it before pregnancy, then ibuprofen can also be used. And you should feel like it's improving a little bit each day. So there can be some discomfort for up to 2 to 4 weeks, but usually by day 10, most women are saying that they feel much more comfortable. You will have bleeding after having a baby, and this should be getting a little bit lighter each day. This can last on and off for up to 6 weeks. If you're having any heavy bleeding or severe abdominal pain, please always let us know. The stitches might itch a little bit as healing takes place, and that's really normal. And you might feel pain or pressure on one side where the sutures have been knotted. And passing urine can sometimes cause stinging, so we recommend that you get a jug of warm water if it's really stingy, and just pour that over yourself as you're urinating, and that just helps with the ammonia in the urine. Also, by drinking lots of fluids, it can help reduce that ammonia, which can cause stinging. When should I contact a healthcare professional? If your stitches are becoming more and more painful each day, or if you suddenly notice that there's an offensive smell, if the wound doesn't seem to be healing, or if you have a pus-like discharge, if you have any problems controlling your bowels, or struggle to make it to the toilet or control your wind, if you have any urinary or fecal incontinence, if you feel unwell, if you have a raised temperature, or if you have any concerns. We are still there for you after you've had your baby. If you were ever worried about any of this, please do contact us. So a common question is, if I get constipated, will the tear open up again? And the answer is no. Opening your bowels is really important, and it shouldn't affect your stitches. Most of the time it's more of a mental block than anything else, and women build it up in their heads, and then once they finally have a poo, they're like, oh, was that it? That was okay. If you've had an OAC tear, you will be given some laxatives to take just to make sure that we're keeping those stools nice and soft. But we still recommend that everybody eats a healthy, balanced diet with lots of fibre in, and drink at least 2 litres of water a day to help keep things soft and to help pass those stools. It's also just good to remember that it might take a day or two, maybe even 3, to have that first poo, and that's okay. Everybody's different. So if you do get the urge and you're feeling a little bit nervous, what will help you open your bowels? If you can get a footstool in the bathroom and put your feet onto it whilst you're on the toilet so that your knees are raised above hip height, this can be really helpful for the position of your bowels. It's important that you try to relax, so don't have your baby screaming outside with your partner while you're trying to do it. You want to be nice and relaxed, rest your elbows on your knees, and it's really important not to strain, okay? Just let nature take its course. If you feel like nothing's happening, then it's okay to bulge out your tummy and take some really big abdominal breaths, which can help, and then just gently push down from your back passage, but do not hold your breath. And most importantly, don't rush. Take your time, relax, and just let it happen. If it doesn't, don't stress about it. You can try again a bit later. Pelvic floor exercises. Pelvic floor exercises are always important. So you should be doing them now during your pregnancy to make them nice and strong. But it's also important that we're doing them postnatally. So we advise that you start them as soon as you can after birth, and that's going to help to strengthen the muscles around the vagina and the anus to improve your bowel and urinary control. You might find that it does feel a little bit weak at first, and maybe you have little sensation, which makes it a bit more difficult, but just keep going with it. It usually improves quite quickly over time, and the more you work your muscles, the quicker the recovery is going to be. You'll also benefit from the fact that that squeeze and release motion is going to get that nice oxygenated blood flowing through the area, which is going to help your stitches to recover more quickly. You should also download apps like the Squeezy app, so highly recommended. It costs a couple of pounds, but it's an NHS app and it is designed by physios to help you with your pelvic floor exercises. There's how-to guides on there, and you can set times to remind you to do your pelvic floor exercises a few times a day. You do your quick ones and your slow ones. You just focus for a minute or two and then that's done. So highly recommend that app during pregnancy and also postnatally when you're trying to build those pelvic floors up again. And if you take a picture of this page, you can scan this QR code later and it will take you through to a video by our fantastic physios talking you through how to strengthen your pelvic floor. That's a great video, so I do recommend that you do that. Looking after yourself. The postnatal period can be quite tough, and it's really important that you look after yourself in order to look after your family. So eating healthily, you might want to prep your food in advance so that you have good healthy meals frozen ready for when your baby's here. That can be really helpful for both you and your partner to not have to worry about thinking, oh, what are we going to cook tonight? Ensuring that you're drinking lots and lots of water, especially if you're breastfeeding. Sleep or nap when possible. Now this can be a hard task because when your baby isn't awake, they are still massive, beautiful time wasters and you want to spend all of your time looking at them. However, it is so important that you have a sleep or have a nap when you can in order so that you feel better and you can take better care of your baby. Always seek help if you are worried, and do look out for things like flashbacks, heightened anxiety, low mood, or if you're struggling to bond with your baby. And know that we're always here if you need to talk to us about any of that. Big question that we get asked quite a lot. Can I have sex following a tear? Of course, the answer is yes. You can have sex again whenever it feels right for you. And just remember that everybody's different and there's no right or wrong. So what you do need to do is consider a suitable method of contraception. You are at your most fertile in the 6 weeks following birth. So unless you want to end up back with us booking your next pregnancy very quickly, we do recommend contraception. And you can talk about your methods of contraception at your postnatal check with your GP also. Some women like to start a bit of perineal massage before having sex just to help loosen the area, massage any scar tissue, and some have reported that this can help you feel more comfortable. You can also use an appropriate lubricant if necessary. And just remember that it might feel different at first, so take it slow. And after a while, that discomfort that you feel initially should pass. It shouldn't be persistent. But if it is and you need to stop, that's okay. Just stop. Talk with your partner about your anxieties and choose a time when you both feel relaxed and ready again. So let's just talk a little bit about choice and consent. So perineal massage, as we said before, is optional. If you don't like it, don't do it. Yes, there is lots of research behind it, but it is optional. Not all tears need suturing, so you can have this discussion with your midwife if you are worried about being sutured. Episiotomy should always be consented in advance, so no one should be cutting you without your consent. You can advocate for your upright, forward and open positions in labour, which we know is going to help reduce your risk of tearing. And remember to always use your brain. So for anybody that hasn't seen this before or doesn't know what it is, BRAIN is an acronym that we use to make sure that you have made informed choices. So if you're not sure about something, you need to ask, what are the benefits? What are the risks? What, if any, are the alternatives? What's your instinct telling you? What's your gut say? And what happens if you do nothing? If you have all of these answered, then you should be able to make an informed decision on whatever it is you're thinking about. So here we have another page that you can take a picture of, and you can scan these QR codes later if you would like to have a further deep dive into caring for your perineum. So you have reducing the risk of your perineal tears from the Royal College of Obstetricians and Gynecologists, a nice information leaflet there from them, and then the last one is how to do good perineal massage. If you have any questions, please feel free to email us at sash.sasha@nhs.net or maternity event bookings. Thank you for watching this course. Please do scan the QR code and leave some feedback, and we hope to see you on our future courses.